I have seen grown men, strong, tough men, curled up on the floor from this pain. This is not heartburn. This is not food poisoning. I'm Dr. BenMaamer, board certified general and vascular surgeon, and I see what happens when this is ignored. Today we are talking about pancreatitis, one of the most severe pain in medicine. The pancreas sits deep in the abdomen, behind the stomach, in the what they call space retroperitoneum. Its job, the pancreas produce digestive enzymes, regulate blood sugar. So in pancreatitis, digestive enzyme activate too early inside the pancreas. Instead of digesting food, they begin digesting the pancreas itself. Autodigestion. So what are the most common cause? The vast majority, it's either gallstone or alcohol. There are other rare causes, high triglyceride and certain medication and trauma. So what doctors see? We do the lab and we found the elevated lipase. We do a CAT scan, we see some abnormality there. On the ultrasound, sometimes we see the gallstone, and that means most of the time it's the cause. And sometimes we see a fluid collection. Imaging may include CT scan, ultrasound, MRCP in complex cases. I don't think that we need to talk about it much. So what patients feel? Sudden, severe upper abdominal pain. Pain radiating straight to the back, very important, to the back. Constant deep pressure. It's accompanied with nausea, vomiting, sweating, inability to lay flat. There is a classic posture. So the patient would be leaning forward for relief. This is not cramping pain. It is constant, deep, relentless. So there are two types of pancreatitis. We call it chronic and acute. For the acute one, by definition, sudden, severe, often reversible. When you compare it to chronic pancreatitis, it's a repeated inflammation, and that repeat inflammation will give like a scarring in the pancreas that will give you a permanent damage. What the result of that? That would lead to malabsorption. You don't have enough enzyme to be used. Weight loss, the consequence of malabsorption. Chronic pain and diabetes because the gland does not secrete insulin because of the damage. So why it gets missed? It gets missed because sometimes mistaken for gastritis, gastroesophageal reflux disease, patient delay going to the ER, alcohol history is minimized, and early labs usually they are not that dramatic. So what are the complications? Pancreatic, we call it a pancreatic necrosis. We can get infection, sepsis, respiratory failure, kidney failure, ICU admission. Mild cases, low mortality. Severe, what we call necrotizing pancreatitis, high mortality, up to 15 to 30%. This is one of the few abdominal pains that can become life-threatening quickly. So when it becomes surgical, pancreatitis itself is usually treated medically. We hydrate the patient with IV fluid. Of course, we control the pain. we put the patient on a fasting mode just to give the put the pancreas on rest, and we monitor. But if gallstones are the cause, treatment often removal of the gallbladder, and the removal of the gallbladder prevents recurrence. And this is where surgical timing matters. So let me give you a red flag checklist. Pain plus vomiting plus back radiation, severe, you go to the ER. So what you should do: seek immediate evaluation if severe upper abdominal pain, pain radiating to the back, persistent vomiting, fever with severe abdominal pain. Leaning forward relieves pain. So what is the prevention? Prevention is we should treat gallstone, limit alcohol intake, control triglyceride, and don't ignore repeated mild attack. This is Dr. BenMaamer. If you believe healthcare in America needs to change, hit follow. We are building momentum one video at a time.